Welcome everyone today to the second in this series of three webinars on digital dentistry. For those who weren't able to join us for the first one, my name's Ed Attenborough and I have a lab in Nottingham. We have a digital production centre and a full service lab. We've been going for over 100 years now, started by my grandfather, and our digital journey started in April 2000. With the UK's first CAD/CAM milling centre, and that's grown over the last 20 years to be one of the largest in the UK and on the radar of the European production centres. So we've got a lot of experience in digital, a lot of experience in dental technology, and we're going to share a little bit of that with you today. Intraoral scanning is really topical at the moment because of COVID-19 and lockdown and cross-infection control. We're seeing a big move now, a real accelerated move towards the use of these technologies to mitigate the risk in traditional impressioning. So without further ado, let's kick off. We're going to be about an hour and a half today, depending on how long it takes. And how many questions we've got to field at the end. So let's have a look at the agenda. We're going to look at how intraoral scanning works. We're going to get an idea of the technology, what it's based on. It comes from desktop scanning, so we're going to draw some parallels there. We're then going to look at a range of intraoral scanners, some of the leading brands of scanner that are currently on the market, and compare the different technologies. We'll then talk a little bit about criteria that you need to make a choice in purchasing a scanner, what you need to be thinking about before you purchase a scanner. We'll go on then to look at CAD, and we'll talk about CAD both chairside and in the lab, because I think there's quite an interesting parallel there and some things to examine in a little bit more detail. We'll then look at scanning itself and protocols for scanning. There will be some videos here. I hope that the technology will behave itself this morning for that. Then we will look at issues that you can find in scanning, just to give you an idea about some of the limitations in the technology as it stands today. So let's have a look at how the technology works. Basically, all of intraoral scanners are based on the same technology as desktop scanners, and this was developed a number of years ago, probably 30 plus years ago. But if you have a look at the scanners here on the screen, you can see a selection of desktop scanners, and the one top left is with a scanner that we started with 20 years ago, and believe it or not, it's still the same technology today. Obviously, the scanners are quicker. They're not necessarily more accurate, interestingly enough, but they are quicker. They've become a lot more advanced. But the basic technology remains the same. And the way that it works is that a laser beam, in this case, is projected on the object that wants to be scanned. So if you have a look here, I think you can probably see my mouse pointer at the image bottom left. There's a die there, and we're rotating that die under a laser beam, and the laser beam casts a profile on the die. And so in this scanning arrangement here, it's a fixed angle of scanning. We've got a laser projecting down onto the die, and also in here we have a stereoscopic pair of CCD cameras, and they're looking at the profile that's cast by the laser on the die from two different angles. And then using triangulation, we can work back to a point in space, just in the same way that we use our two eyes to look at something from two different angles, and that gives us a 3D perception of depth. So exactly the same principle in optical scanning as to our own eyes. The scanning technologies here are typically, on a desktop scanner, accurate to around 5 to 10 micron. They output in an industry standard open file format, which is called STL. So once the scanner's recorded the point cloud of data by rotating the object under the laser beam, it then takes all of that point cloud, individual points in X, Y, Z space, and changes it into a triangle mesh, which represents the surface anatomy of the object that's being scanned. Now, that's quite a clever file format. STL stands for stereolithography, and that comes from the original 3D printing back in the 1980s. And the way it works is that it has a mesh of triangles that represents the surface, and it's quite clever because it means that it self-optimizes. Where you have more anatomy and you need more detailed surface registration, there will be a higher density of triangles, and where the anatomy is smoother and there's less detail, there'll be less triangles. So it's almost like a 3D optimized zip file in a way, that it uses the minimum amount of data necessary to represent the anatomy. Now, laser technology has certain advantages in that the laser beam has an infinite depth of field because its sides are parallel, the sides of the beam are parallel. So the laser is in focus at 0 and at infinity. And that's quite useful because it means that the accuracy of the scanning isn't related to the depth of field. And that's important, as we'll come on to find out about. So optical scanning is the common technology that's used in all intraoral scanners, and it comes from desktop scanners. So the second technology that came a little bit later in the mid-2000s was called structured light. Same principle, we're projecting a pattern onto the object to be scanned. In this case, it's kind of like a barcode pattern. And what we're using is the DLP light processor from the same kind of projector that you would have for a PowerPoint presentation. And we're projecting a pattern of stripes or lines on the object. And then we're capturing that pattern with a stereoscopic pair of cameras, just like in the laser scanner. So we're looking at the pattern from 2 different angles. The advantage of structured light scanning is that, of course, we've got lots of lines cast onto the object in one exposure or position of the gimbal that's rotating the object under the projector and cameras. So the speed of data acquisition is much faster. The disadvantage is that, of course, just like your PowerPoint projector, it has a certain depth of field through the optics to project this pattern, and it means that the pattern's only in focus within a certain depth of field. So depending on the distance of the scanning arrangement from the object, the accuracy of the recorded data can vary, but the data acquisition rate, the speed of scanning, is much higher than laser scanning. The other disadvantage of structured light scanning, certainly in the early days, was that it used white light. Now, as we all know, white light is made up of lots of different wavelengths of light, and when that light passes through optics, just like the rainbow effect with a prism, it diffracts to a different extent depending on the wavelength of light passing through, and that can cause a measurement error called chromatic aberration. So we saw in the late 2007-8 that these technologies started moving to, certainly in the lab scanners, which didn't need color information, to a monochromatic source of light, and they settled at that time pretty much universally on blue light. However, you can still do a multi-scan where you scan with blue light for an accurate scan and then quickly expose in white light to capture color information, which can be overlaid. So the second file format that is also now an industry standard open file format is called PLY, and PLY file format is the same as STL in that it represents the surface of the object with a triangle mesh, but then on the triangle mesh it overlays a skin which represents the texture and color of the object that's being scanned. And so now there are 2 file formats, certainly in intraoral scanning, that have become very popular, and they are STL and PLY. So if we can remember those various attributes, let's have a look now at intraoral scanners. As I said, exactly the same principle. Some of the scanners here have been around for quite a while. This is obviously CEREC Prime Scan from Dentsply, which originally came out in the mid-1980s. Now that system originally was a proprietary file format, so it was a closed system, a bit like VHS and Betamax years ago for video file format, video recording file formats. CEREC had its own proprietary file format that meant you were locked into a certain workflow. Same story with iTero and 3Shape and others actually. But again, in 2007, there became this movement for open systems and interchangeability of file formats from one system to another. And now that movement has really won the day. And one of the first questions that's on people's lips is the system open? So now you find with systems like CEREC or iTero that they can run in a proprietary file format, or they can upload the data from the Intra Oral Scan into the cloud using an open file format. So that's certainly something that you want to be thinking about when you're making a decision about purchasing. Obviously, we can see iTero here. Again, that has now gone open with a restorative workflow as well as the orthodontic workflow, so that you can upload STL data and that can be downloaded by your local lab or any production center such as ours to manufacture the restoration for the crown and bridge workflows. Here we can see the 3M scanner and also here the Trios scanner. So the way these devices work, as I said, is exactly the same as the desktop scanner, but there's a slightly different form factor, which is obviously necessary for comfort of the patient in terms of scanning. So the first thing is that they're all based on a periscope arrangement. If you can see the mouse pointer here, there's a mirror at 45 degrees, and all of the clever stuff, the electronics, is in the handle of the device here. So there's a laser or a projector in the handle of the device here, which projects light, either structured light or a laser beam, down the axis of the intraoral scanner wand. It's reflected off the mirror and onto the tooth or prep or the object that's being scanned. That reflects light back up, which is captured by the mirror and then reflected down back into the handle, where the stereoscopic cameras capture the image from two different angles and merge it back together. So a couple of things that we can see straight away in intraoral scanning that are going to be probably more restrictive than desktop scanning. The first one is, obviously, there's only a certain vertical dimension that we can have here for the comfort of the patient, particularly if you're scanning in the molar region. So that restricts the overall size of the tip of the wand, and the window here therefore can only be of a certain size, and that gives only a certain size of the viewport that the scanner can see. So typically all intraoral scanners can only capture 2 or 3 teeth in one view or image, and when they quote accuracy, quite often that is accuracy on individual scans as opposed to the entire arch. So you will always find with intraoral scanners that on single tooth or prep scans, they're more accurate than across the whole arch. Because the way they work is that they capture a single image, and as you move around the arch with the scanner, it's the software stitches the images together. So it basically stitches a whole set of images. Frank, if I can ask you to put your question to the end, and then we'll field the questions at the end. There's a little section there where you can put the Q&A questions if you want to do that, and then I'll come to them at the end. Thanks ever so much. Basically, as we move around the arch, the software is stitching individual images or video together to create a composite image. Now, each individual stitching process carries its own error or measurement uncertainty as well, because obviously we can't exactly stitch those images together. They might have slightly different angles where they fit together, given the measurement uncertainty of the device itself. That means as you move from molar to molar across the arch, you'll get a cumulative error, which is significantly more than the individual error of the individual scan. And that may be 60, 70, 80 micron. So that means that the devices are suitable in terms of accuracy in certain indications and less suitable in others. And we need to have that at the back of our minds, that there's a measurement uncertainty that's caused by the software interpolating the data as it's recorded from the wand and turning it into a 3D file. Obviously, there are a lot of other challenges in the oral cavity that we don't have with desktop scanning as well. There's soft tissue, there's saliva, there's reflective surfaces of standing restorations, and all of these things cause artifact, which we'll come on to look at a little later on. It's worth saying, thinking about lockdown and COVID and SOPs and AGPs and coming out of lockdown back into practice, that the hardware now universally, I would say, is of age. It's come of age, and I would say that most of the devices that are on the market now, from a hardware perspective, are well proven and functional. From a software perspective, that's also very competent and capable, but it's somewhat of a moving feast, and we're seeing new developments come out in the software very rapidly at the moment. So if you were thinking about making it, investing in this kind of technology and worried that you might buy something that was obsolete in a few years' time from a hardware point of view, I think now that's not the case, because most of these devices are pretty much there in terms of hardware capability. Yes, the software is still advancing very rapidly, but that's updates and downloads that are usually part of or included in the package when you purchase one of these devices. So I think you shouldn't be too concerned at this stage now about the hardware aspect. They really have become very competent. So some little tips there about scanners. Let's come on to look at a range of scanners. Now, obviously, I don't have any particular in this particular presentation bias towards any scanner. We do resell scanners, and we'll come on to talk about that at the end. But what I want to try and do is give a quick overview of some of the leading brands of scanner on the market, and there are, as they say, others out there as well. So the first one we're going to look at is iTero, and this comes in various different formats. We're going to look at the Element 5D, which is one of the most recent versions of this. It's based on a parallel confocal laser scanning technology, and that obviously we saw in the first slide. The weight is around 500 grams, and it uses near infrared imaging, which is quite nice actually, because infrared will penetrate soft tissue and tooth structure to a certain extent. So that gives certain advantages in terms of detecting internal caries in teeth and also being able to record subgingival margins. The scan is typically around 60 seconds for a full arch. Remember that we have to do both arches and a buccal bite scan as well. So typically a scanning session will take around 2.5 minutes, which I think is comparable to taking a classic impression, upper and lower, and a wax bite. Obviously, it's a fully open workflow now, so you can go down the closed workflow through a line for their orthodontic workflows, or you can go through a restorative open workflow and integrate with any other lab that has the ability to receive the iTero files. So they have a portal that uploads that. It comes in a different formats, including a laptop plugin and a cart format as well. You can see that the technology's moved on very rapidly. This is only a few years ago, and you can see that obviously it's miniaturized a lot. I really show this slide to show you how much the hardware has moved on in the last 5 or 10 years, and that it's pretty much there now. So there's a little video coming up now that I'm going to show you, which takes you through that technology. And once that's finished, we'll go on to look at some of the other brands that are out there. Hopefully this is going to run okay.
Imagine a platform that propels your practice into new dimensions. a platform that allows you to see beyond the current spectrum of what's possible for patient engagement and digital workflow. Hi, I'm iTero Element 5D, and I add a new dimension to your practice. With one integrated scan, I provide an array of powerful visualization capabilities at your fingertips. I provide you powerful tools to aid in your diagnostic, restorative, and orthodontic workflows. I'm the first integrated dental imaging system that simultaneously records 3D, intraoral color, and near-infrared images and enables comparison over time using iTero time-lapse. NIRI helps you see your patient's internal tooth structure to aid in detecting and monitoring the progression of proximal caries from multiple angles. My built-in intraoral camera pairs with NIRI technology to take clear, precise images, giving you a new level of visualization. Rotate the 3D model and watch as I match the NIRI images and intraoral images with the angle of the scan in real time. Without harmful radiation, you can scan patients at every visit for comprehensive care. My software also includes iTero exclusive applications like the Invisalign Outcome Simulator, Invisalign Progress Assessment, and iTero time-lapse technology. I help you elevate your digital workflow, engage patients with easy-to-understand visuals that show them what you see, and set your practice apart with cutting-edge visualization technology. In a single scan, I help you visualize a new spectrum of dental care, beyond what the eye can see.
Okay, so that's the iTero element. It's interesting to note that it works in a dual mode. I think we roughly touched on that earlier on, in that it does an accurate scan monochromatically, and then it can do a color scan using white light. And we'll see that dual mode or multimodal scanning in later in the presentation. So this is the Medit, which is another brand of scanner from the Far East. Structured light, this one's based on, and this is a fully open system. The wand is slightly lighter at 276 grams. It has a full arch scan in 60 seconds, which is comparable to all of them, and an open workflow, as I mentioned. Now, obviously, iTero is integrated with the software. So it has integrated software for orthodontic, and iTero now also own Exocad, which provide a comprehensive suite of other workflows, including crown and bridge, prosthetics, cobalt chrome prosthetics, etc. So with iTero, you get an integrated software suite. With the Medit system, it's a standalone scanner. So basically, you're buying a hardware device, which will plug into a laptop and output in an SDL file format. And then you have to integrate third-party CAD software, such as Exocad. Now, I know that Align have made a commitment after having purchased Exocad to keeping that software open for everybody to use. But as I say, you do have to put these different elements together rather than having an integrated suite with the Medit. 3Shape is a very popular unit. This is the Trios 4. Again, it uses structured light technology, so it's projecting a pattern onto the die and recording that from two different angles. 3Shape Trios comes in a wireless version as well as a wired version. Exactly the same periscope technology as we've seen in others. Quite nice with this periscope design, in common with all of them, that the sleeve is removable, so you can take the sleeve off and autoclave it, sterilize it. So that's quite a nice modular design, and I think all of the scanners have settled on that design now with a removable sleeve, and you can get different sizes of tip on the wand as well, depending on the scanning indication. 345 grams, so a little heavier in between the Medit and the iTero. 25 seconds of full arch scan, so it's quite fast. One of the things I would say when you get reps demonstrating these devices is that a lot of these devices have a demo mode, and the demo mode generally is a fast scan mode, which works at a lower resolution. I would always recommend, if you're looking at buying one of these devices, to try them yourself and not on a model, try them intraorally, and then you'll really get a feel for how they work and how long they take to scan. Again, 3Shape is an open workflow. It did have a proprietary file format originally, but it's fully open now. And it comes with its own integrated suite of software. So this is more like the iTero in that you're getting a whole package rather than a basket of individual solutions that you have to put together. 3Shape comes in all sorts of different formats. There's the 3Shape Move, which is one of the more recent ones, where it has the touch screen on a kind of angle poise arm with the wand actually clipped on the side to form a very easy cart to move around. There's a lot of debate about cart versus laptop. Most of them come in both formats. I think there's obviously an attraction to using laptops, you know, USB, etc., plugging the things in. But I think you have to ask yourself how practical that be in terms of sterilization and cross-infection control. The other thing is with laptops, where do you put the laptop? Typically, we see that clients will put the laptop on the cabinetry, and then the wire will be stretching across from the cabinetry to the chair, and that's a kind of trip hazard. You know, a nurse, somebody else could go around there and whip the laptop off the bench, so to speak. So I think probably integrated solutions that are easy to sterilize and keep clean are probably going to be more popular in time to come. But of course, obviously with a laptop, it's very flexible. You can just plug it in and it's easy. But your laptop does have to be matched in terms of specification to the manufacturer's requirements for the wand hardware. So you can't just go and buy a wand and then buy a laptop from Dell or eBay and plug it in. It just won't work. They have to be really well matched together. So integrated solutions, I think, are probably going to become more popular. You can see here the 3Shape portfolio. So as you say, we've got the Trios 4. You can do a wireless connection. That's available in Trios 3. It's available in a pod, which attaches to a laptop. It's in the Move format, and the Trios 3 is also available in a cart format. So lots of options there. Of course, if you practice is on different levels, and you're not going to equip every surgery with a scanner, and you're going to share it between surgeries, then obviously the practicalities of carrying it up and downstairs need to be borne in mind, and maybe that does make the laptop solution more attractive. These are all questions that need to be thought about when you're selecting the right technology. The next one we're going to look at is the Dentsply Sirona Prime Scan, obviously from the CEREC heritage and lineage, a very well proven technology. Again, works on structured light, same periscope principle as the other ones we've looked at, with a removable autoclavable tip. 524 grams, so slightly heavier, and 60 seconds to do a full arch scan. As we said, CEREC is now fully open with CEREC Connect, so you can upload your scans into the cloud, or you can mill them chairside. And I suppose another factor to be thinking about in making a purchasing decision is the integration of the technology with other technologies within the practice, such as dental practice management systems, milling systems, chairside milling systems, 3D printers, and CBCT units. So quite a few of the technologies that we've looked at already have that multi-workflow integration, and I think that's something for you to consider. But a very well proven system, and the software with Sirona is obviously very mature. It was one of the first technologies to come out. So there are lots of nice, interesting features in that we'll come on to talk about a little bit later on. The Plan Mecca Emerald is one of a suite of 3 different ones that are available. It uses red, green and blue lasers, projecting a pattern onto the die or tooth, and that is obviously picked up by triangulation. It's a full color system, as are all of the systems that we've seen so far. So they all record color and overlay that color and texture detail onto the triangle mesh in a PLY format. It's very light, the Plan Mecca Emerald system, at 229 grams, and quite fast at 30 seconds for a full arch scan. And it's a fully open workflow. Again, same principle with the clever stuff in the handle and the periscope and the removable tip. The Plan Mecca has an integrated ecosystem called Romexis, which is almost like an operating system, same as 3Shape and the Prime Scan have. So it includes CBCT, CAD/CAM, milling, 3D printing. All of that is integrated into one software suite. So you've got very slick integrated workflows, and also the ability to output in STL file format for open third-party manufacture if you choose to do so. So very nice unit, comes in various different formats, typically plugs in on a USB into a laptop, but a very nice piece of hardware there, and mature, well-supported technology. Similarly, Carestream, this is the 3rd incarnation, started off with 3500, then the 3600, and now the 3700. Structured light, so it's projecting the barcode patterns onto the object. Clever stuff in the handle again, periscope, removable tip, 316 grams, so kind of in the middle of the field in terms of weight. 60 seconds for a full arch scan, and a fully open workflow. Carestream has its own environment as well called CS, and that includes CBCT and milling and various other different options, so CAD/CAM options. So a well-proven technology, 3rd generation, and quite popular, well integrated with other items on the market. The Dental Wings Virtuo Vivo is owned by Straumann now. This is one of the smallest, most compact ones or handpieces on the market. It uses blue laser technology, but it records in full color. It uses a multi-scan imaging technology, like we discussed before, where it'll scan accurately with a blue light, and then it'll record color in a white light. 30 seconds for a full arch scan. Again, you can see the form factor here is very thin. Obviously, I haven't got them next to other ones, but I think you'll probably see in the pictures on the videos later on the kind of size of it. Full color scan, outputs in PLY format. So, you know, you get the texture as well as the color out of this device. And it's a fully open workflow, outputting in STL file format. The Virtuo Vivo portfolio includes CART, and there are two versions. There's a CART version and there's a portable version. So the CART version probably just to be used on one floor in a surgery, or multiple floors upstairs and so on and so forth. There's a little portable integrated version, or it does come in the pod version, which plugs in via the USB to a laptop. You can see some of the advantages here in terms of the design of the device. Most devices actually have a heated mirror to prevent fogging. That's quite common, and obviously it has a special coating for comfort for the patient. Very nice hardware, and probably shows the future of the form of these devices. And we can see with the Virtuo Vivo, it integrates with the Dental Wings suite of software, which is chairside and lab, and includes image guided surgery. So you can do co-diagnostics, which is their image guided surgery module, which merges CBCT data, as we'll look at in a minute. You've got the CARES visual chairside software. You've got Smile Design interfaces, orthodontic interfaces, and various other services. So this is a complete integrated system and software, which makes it quite attractive. And then just quickly to finish, I show Lonka, which is one from the Far East, from China, and we're seeing these ones come on the market now, and their technology is really maturing and catching up, and I would say the hardware's pretty good now. They work very much like the Medit, so the Medit's Korean, Lonka's Chinese. They basically are an open format USB driven device that plugs into a laptop, and then you have to pair it with third-party software, be it Exocad or Dental Wings or others that are on the market. Again, it works on a structured light format and takes around 68 seconds for a full arch, and is a fully open workflow. I think interesting dynamic now in the market, because not only is the technology there in terms of the wand, but obviously with the global competition coming into market, it's becoming a very competitive space, and obviously there are some good deals to be had out there. So just to summarize, in terms of choice of scanner, what are the things that you should be asking when you're thinking about getting one of these devices? Well, I say first and foremost, always try it in the practice and do your own scan on a patient to find out how it works. Think about what workflows you want to do. Do you want to do just orthodontic? Do you just want to do restorative? Do you want to do implant work, or do you want to do a combination? And this will tend to narrow down your choices in whether you have an integrated system or a pick and mix system where you put together third-party software and handpiece. Is your practice on one level, or is it on multiple levels? So do you want a cart, or do you want a laptop version? I would definitely say open scanning, STL file output is very important, as is color scanning and texture scanning. So these are some of the things that you should be thinking about, as well as interconnectivity. And as I say, once again, just to reiterate, always try it in the practice yourself on a patient, and get a hands-on feel for how the technology is working. So I hope that was helpful in terms of how things work, some of the scanners on the market, and the choices that you need to bear in mind when making a purchasing decision. We're about halfway through, so we'll come on now to talk about computer-aided design. We've touched on that, but it is part of the overall process in terms of making a decision about how you're going to work with this technology, what your workflows are going to look like. So having a look at CAD here, basically chairside CAD, anything that we can do in the lab in wax can be done digitally in chairside CAD now. So the software is very capable, and the question is not whether it can or can't be done chairside, but whether it should or shouldn't be done chairside. So we can see here that the automatic design proposition for crowns is really good: contact points, occlusion, so on and so forth. So simple single crowns, software is really great. We can also do inlays, onlays, veneers, obviously complex bridge work, and we can do implant-borne restorations as well. So the software is extremely competent. We can do ortho, not only crown and bridge, obviously we do ortho workflows, and we can do removable, we can do aligners, we can do fixed bracket work in CAD. All of these things are possible either chairside or in the lab. But let's have a look at one particular workflow, and hopefully this will help us to think about what we actually want to do with this technology in the practice. And this is for designing in CAD a cobalt chrome partial, and this is actually lab version of the software, but you could also run this chairside, and this is from the Exocad suite. So first of all, we've got our scan. In this case, it's a scan of a model, but it could also be an intraoral scan. The first thing we've got to do is we've got to survey the model to work out a path of insertion for the final cobalt chrome partial. Now, normally that would be done on a surveyor in the traditional classic process, and it's a very similar process and workflow digitally, and you can see the undercuts that are represented. Once you're happy with the path of insertion, and that is quite a fiddly process, it's not something that lends itself to a touchscreen. That's the kind of thing you want a keyboard and mouse to do. It's a multiple hand sort of a process. Once you've decided on the path of insertion, you have to block out the model just as the technician would block it out in the lab, and that's done digitally. Once the model's blocked out, you have to carve into the undercuts a position for the clasps to engage. Again, that's quite a fiddly process in terms of moving the model around, sculpting the virtual wax out of the model. And you've got to very carefully design where the clasp is going to sit in that. You've got to design the grid, the retention, and lay it down on the model with a relief, of course, underneath digitally for the acrylic to be processed eventually. You've got to design the bar or connector, and you've got to merge the whole set together. Now, this is quite a complex process, and I would suggest doesn't lend itself to chairside design. Far too fiddly, and really at the end of the day, I suppose you have to ask, you know, when you're in practice, it's about seeing patients as much as possible, and how you value your chairside time, and do you want to spend half an hour? I mean, you know, it may be of interest to do so, but does it make sense to spend half an hour designing a partial chairside, or would it make sense just to use the intraoral scanner as an impressioning device, capture the 3D recording, upload it into the cloud, get the lab to do the design, and upload it back to you to download into the practice? So I think we need to think about what things make sense to be done chairside and what things make sense to be done in the lab. And where there's an automatic design proposition, you know, if that's easy to manufacture chairside in terms of a chairside milling unit for a composite or provisional restoration, then great. But if it's more complex to manufacture in terms of casting a cobalt chrome framework by 3D printing the wax up, as you can see here, and then investing and casting, processing, finishing, you know, should that be done chairside or should that be done in the lab? So I think we can already begin to see that some of the natural steps and boundaries in the workflow from the classic workflow transfer across to the digital workflow about where it makes most sense to be doing things. Again, here, a second example, designing a simple 3-unit bridge. Now, that is quite a bit more fiddly than it is to have an automatic proposition for a crown, a single crown, maybe a temporary provisional crown, and a lot more manual intervention in terms of printing the wax up, investing and casting it. So I would suggest that before we come on to talk about image-guided surgery, that things should happen where they need to happen, and we should perhaps view the intraoral scanning devices as primarily impressioning devices that have the ability to do some workflows and treatment augmentation chairside, and we'll come on to look at some of those others, but certainly automatic design of provisional restorations and milling chairside is one very good application of it, as is orthodontics and outcome simulation, as mentioned in the video we saw earlier, but we'll come on to talk about those in a bit more detail later on. Now, the second thing that we need to discuss is how these intraoral scanners integrate with the rest of the kit in the practice. And perhaps you have a CBCT unit in the practice, perhaps you refer patients for a CBCT, but we want to be able to merge the data from the intraoral scan with the DICOM data from a CT scan to do image-guided surgery potentially for treatment planning. And this is where open systems are critically important, so that you can take data from one modality, scanning modality, merge it with another, create a composite image, which can be then used for treatment planning. In this case, for the placement of 2 anterior lower implants. And the way the process works is that merging the intraoral scan data with the DICOM data improves the accuracy of the DICOM data. You can actually see here, CT data typically works on 1/2 mil slices. Obviously, the resolution of CT data is directly proportional to the amount of radiation dose that the patient's given. So typically, it's 1/2 mil slices or 0.25 mil slices, and that is fine in terms of looking at bone density and planning where the implants are going to go. But in terms of restorative resolution, we need a higher accuracy. Also with CT, of course, you get artifact from standing restorations, PFM or all metal restorations or amalgam fillings. And by merging the optical scan data from an intraoral scan with the CT scan data, we can create a composite image that eliminates the artifact and is accurate enough not only for planning where the placement of the implants will be, but also the restorative planning. And this is a kind of hybrid workflow which involves a clinical element of planning on a workstation and a restorative element of planning. And those two workstations don't actually have to be side by side these days. So you could be planning where the implants are going to go in the surgery, and in real time, using Synergy, the Co-Diagnostics Dental Wings product, the lab can see where you're placing the implants, and they can start to plan the restorative element. And when you're both happy with the treatment plan, you can then print a surgical guide to enable accurate placement of the implants. And you can see one designed here, which is fenestrated, so you can see it's fully down on the teeth, and it provides slots for concentric sleeves to be placed in on an interference bit for guiding the shank of the drill to place the implant accurately according to the plan. With Synergy, and this is where integrated systems like Remexis and 3Shape and Dental Wings come into their own, and Carestream. Basically, you can plan both aspects, the clinical aspect and the restorative aspect, under one session. So once you've decided where your implants are going to go, we can start to design the restoration, the customized abutments, and in this case, 4-unit provisional restoration, so that they can all be placed in one visit. And this kind of integrated treatment planning really comes into its own when you have an integrated system and software. And you can see here the third modality that will be coming in, and I only touch on this because we covered this in the first session, but facial scanning chairside is becoming quite important now. And this can be done with an open app on your iPhone or your Android. The app for iPhone is called Bellis 3D. Basically, you can take a 3D scan of a patient's face using your phone, and that is output from the app in STL file format. And then the software uses anatomical landmarks to co-locate the images, so that basically you can do a facial scan of a patient, you can do an intraoral scan, you can load that data up into the cloud, it can be downloaded into the lab, they can then do a virtual diagnostic wax up, for example, send that back up into the cloud and down into practice, and you can then consult with the patient, explain the treatment plan to them, and get them to buy into that treatment plan. So really powerful, integrating, great image for the practice as well, in terms of patient communication. So that's kind of where the technology is going, and we can see those three modalities: intraoral optical scanning or model scanning or impression scanning, CBCT, and optical facial scanning, those three different strands coming together to create a composite image that we can do all sorts of clever things with, either in real-time chairside with outcome simulation, or offline or semi-offline by uploading to the lab and getting them to do a virtual diagnostic wax up. So now we're going to come on and look at the actual scanning process. I've got a couple of videos to show here and then a couple of slides. So I may have to just skip screens. If you just bear with me 1 second, I will just sort that out. All right. Hopefully you can see that.
This video highlights a few key tips to scanning efficiency that will support your full mouth scanning protocol. The iTero Element intraoral scanner allows me to scan in a continuous motion to capture a full mouth scan in as little as 1 minute. I always rest the wand tip gently on the patient's teeth. I never hover. I only need to press and release one of the side buttons to start and stop the scanner. I keep the scanner on while I scan an entire arch. When I'm scanning the occlusal surface, I am careful to orient the cable end of the wand away from the patient and bring it straight out of the patient's mouth without twisting or turning the wand. As I scan, I will bring the wand around the arch, maintaining this orientation. In the occlusal scan, when I come to the anterior 6 teeth, I tip the cord end of the wand up to capture more surface area and lingual anatomy, rather than scanning only the incisal edges. When I transition to the lingual, I bring the cord end of the wand out to the side. Then, in a smooth motion, I bring the wand around the arch, keeping the wand tip tilted towards and facing the anatomy I am scanning. I'm always careful to roll over the occlusal of the terminal tooth when I'm moving from the lingual to the buccal. This ensures that the model builds smoothly. While scanning the buccal surfaces, I orient the tip of the wand at a 45-degree angle to the buccal surface, with the cord end facing away from the patient. I follow the arch with the wand as I move toward the anterior. At the midline, I will remove the wand from the patient's mouth, place it on the occlusal of the contralateral terminal tooth, roll to the buccal, and follow the arch around to the midline. I use a rocking motion while scanning the buccal and a rolling motion while scanning the lingual to capture the interproximal surfaces, pointing the tip of the wand toward the anatomy I'm intending to capture. In the bite segment, I only need to capture 3 to 4 teeth and the upper and lower gingival tissue. I do not need to wait for the bite to attach to the digital model before moving to the contralateral side. While scanning, I focus on the model on the screen, so if it stops building, I can quickly go back to the last area that was captured. I use the wand tip to help retract the cheek, lips, and tongue. I use the fingers of my opposite hand for retraction and to guide the tip during scanning. While I'm scanning the buccal, I often switch hands when I reach the contralateral side. To capture clean incisal edges, I make sure not to rush my rollover scan of the lateral and incisor. I start on the incisal edge, roll to the lingual, and slowly roll over the incisal to the facial. Additionally, I can glide over the incisal edges from first bicuspid to first bicuspid to capture additional incisal information. Marks to guide me to fill areas of missing anatomy. Missing anatomy alerted by the red and purple marks needs to be filled no matter how small an area. However, holes without red or purple do not need to be filled no matter how large. I use the broom tool to remove any unwanted structures from the digital model. I use the fill tool to fill persistent areas of missing anatomy. I always have fun when I'm scanning. No more goopy impressions.
All right. So, couple of points there before we go on to the next slide. The structured light scanners have a certain depth of field. So you can see with some of the scanners, they tend to rest on the teeth. You do need, if you're not resting on the teeth, you do need to rest your hand in a way that you're steady, because obviously jittering around with your hand is going to cause multiple recordings, and we'll come on to look at some of the issues that can cause a little bit later on. The other thing to mention is the stitching, particularly as you come round the lower 2s and 3s. All of the scanners that I've seen sometimes slightly misstitch. And what happens then is that you get a slight compression of the arch. And it's quite clever, because once you scan the opposing and you do the buccal bite scan, the software places the models in virtual occlusion and works out if there's been a certain distortion of the arch, and then it kind of clicks out. You can actually see the software correcting. Now that's great, because you know, it's self-correcting in the same way as it can automatically fill holes. But let's remember that's not recorded data, that's interpolated data from the software surmising what the arch should be. So there is inherent measurement error introduced not only in the hardware of the recording device, but also in the software which is interpolating the data. So let's just have a look at another video here, and I'll run through that with you. If you just bear with me a second. And this is showing the Plan Mecha system, a similar protocol, but it's just interesting to compare two different protocols. Here we go. Hopefully you can all see that okay.
Retraction devices are recommended to keep the lips and cheeks away from the scanner. Dry the teeth before starting the scan.
We may have a bandwidth problem here, trying to do too many things at once. Let's have a look. I can just trigger that along.
Scanning is easier when the patient is in a horizontal position. Hold the scanner close to the tip like a handpiece. Rest the neck of the scanner gently on the adjacent teeth. Press the upper button once to activate the scanner. Start the scan from the occlusal surface with the tip of the scanner pointing towards the distal. On the interiors, rotate back and forth from the palatal to the facial. It is important to capture data on all three surfaces. Scan the occlusal surface of the entire arch. Next, scan all of the buccal. The scan should continue from the occlusal surface already scanned and overlap with it. Scan all of the palatal. The scan should continue from the occlusal surface already scanned and overlap with it.
So you can see the color overlay there in real time, which is quite nice. I think using Optrogate is really useful, actually. Cheap retraction. Some people also put dry pads in as well, and use aspiration. You can see the protocol here. Scan one arch, scan the other. Typically, starting on the molar area because you get the occlusal anatomy, which gives more registration points, more anatomical detail for the software to start stitching to. And all the different scanners recommend different scanning protocols, particularly in the anterior region. You can see that iTero kind of recommended rolling over one way, and Remexis, Planmeca, Emerald recommend rolling over another way. So I think we'll stop it there.
The model of the scanned teeth.
And go back into presentation, if you'll excuse me a second. Okay, so that's the iTero element and Planmeca protocols. As you can see, they do vary slightly, but it's the same basic principle. And I think mostly it's around the hardware and how the hardware is working, and the software algorithms that are doing the stitching together. And you'll find, and that's why it's important to actually get a hands-on feel for these devices, your own individual way of scanning that you're most comfortable with and yields the best results. Have a quick look at the Straumann Dental Wings Virtuo Vivo scan protocol now. Again, subtly different, but it's useful to compare the three. So again, we're starting on the molar region. This technology is based on blue laser light, but it's recording, overlaying white light, color recording of the anatomy and color of the teeth. Similar process, rolling over the incisal edge there. You can see that there's a certain amount of artifact there, which is basically soft tissue. And as we'll come on to look at in later scans, that can be either manually or automatically removed. But you can see the process there, and again, you know, done in 30 seconds, something like that, maybe a minute. Very fast scanning protocols these days. So that gives you an idea of three of the scanning protocols. And again, the Launca one we could look at there, but I'll probably skip over that. They're using retractor, similar process, but I'm just mindful of time here, so let's skip over that one. So one of the things to talk about in real time, which is absolutely great with this technology, is if you've selected what type of restoration you're going to have, maybe it's a zirconia crown, the software knows what vertical dimension is required for that and what type of margin. So the software can provide real-time feedback in terms of the prep to let you know whether you need to take, whether you need to do a more invasive prep, whether you need to adjust the margin. And also the software can provide real-time feedback of occlusal contacts. The process with bite registration is, as we discussed, basically taking upper and lower full arch scans and then doing a buccal bite scan. Now, obviously, because the full arch scans have three-dimensional data that's correcting the point cloud, they are more accurate, whereas with the buccal bite scan, you're just scanning to the buccal and almost peeling it out. So that obviously causes an inaccuracy, and then what the software has to do is to automatically identify anatomical landmarks on both scans and merge the data together to put the models into occlusion. And this can always cause a certain uncertainty, and as a rule of thumb, with the buccal bite scan, the more data you can capture, the better. Really take your time. Most people whiz around in 15 seconds, but the more points you've got, the more accurate the occlusion is going to be. And that's, for a full digital restoration that's produced without a model, that's going to save you a lot of time potentially adjusting the occlusion chair side once you receive the restoration. The other point to bear in mind is implant work, and obviously we talked about whether or not you can see a subgingival prep, and intraoral optical scanners can only record what they can see. The way it works with implant workflows is that you use something called scan bodies, which are like little reflective abutments made out of PEEK, which engage with the fixture head and have a known shape on the top. In this case, a little flat on the side there. And then the software compares that shape from the scan to a library of shapes that it holds for scan bodies or abutments. And it can then extrapolate back to the accurate position of the fixture head from a scan of the top of the scan body. So that's typically the process for implant work. So margin scans, obviously always a challenge. We have to look at whether they're subgingival or not, and we'll come on to talk about that a little bit later on. Suffice it to say that the software these days always provides, whichever scan you're using, a real-time feedback of the scan, and so it identifies where data might be missing. So if you've missed part of the scan, I think it's always good that the software lets you know where that is and gives you the option to go back and rescan it or to automatically fill it. I'd far rather I knew what was genuine data and what was interpolated data than letting the software quietly behind the scenes just fill everything in. We've got more control over the process that way. So that would be another one of my decision-making criteria, having that transparency in the scan of knowing, having that additional information, and then making a decision about whether to interpolate or to rescan in particular areas. And again, margin identification, software allows this to be done chairside or in the lab. I think it's no bad idea to verify the automatic margin identification chairside before you transmit the data to the lab, because you're in a position, you've got the patient in front of you. If there are any errors, as in bottom right here, where the software has not accurately identified the margin, you can then correct that before uploading it and save an awful lot of time and bother. Also, the software will show undercuts. So if you've got an undercut on the prep, it will highlight that, and you can go back in and adjust it if you want to before proceeding and then rescan. And here we can see again some examples of where automatic margin identification needs to be adjusted manually before transmission. And I think it's a good idea to do that chairside if you can and you've got the time to do it. So a couple of other things that we've kind of touched on, and this is where not only is the software great for helping you show that your prep is appropriate and giving you that real-time feedback, but also in predicting outcomes. So iTero have an outcome simulator so that they can actually simulate what the patient will look like if they have the treatment done. And that is a great planning and communication tool for the patient, and very, very useful. So we're going to see the automatic design propositions, the automatic analysis of preps and bite, and the outcome simulation as a big growth area in the software. But again, that shouldn't be something that makes you pause and think, should I dive in now or should I wait? Because again, the hardware is there, it's the software that's moving very quickly now, and some really powerful tools to help your practice and your clinical workflows. The other thing that's quite nice is that, particularly with some of these IR infrared or near infrared technologies, they can penetrate slightly deeper than the actual surface of the object being scanned. And this helps in scanning subgingival preps which normally you'd have to use retraction cord for. You still do, but it makes it better and more accurate. But also in automatically identifying caries. So we can see here, this is a feature with Trios, the 3-shape scanner, that it will highlight potential areas of caries. So AI, artificial intelligence in software, is a big growth area, and I think we're going to see a lot more of this in terms of the intraoral scanner becoming a diagnostic aid as well as a recording aid in the future. So, coming to the last point, and we're just about 1 hour and a quarter in, so we've got about 10 minutes to run. Let's talk about some scanning issues, just to sort of open our eyes to the fact that all technology has its limitations, and how to overcome them. So the first issue I'd like to talk about is missing scan information, and we have touched on this already. You can see here on the left, the adjacent tooth to the prep has got an area missing because of the shadow cast by the prep, because the angle that's been the scan has been placed. So the software here is actually highlighting, and this is a Remexis software. It's saying on the right-hand picture here in the blue area, look, we are missing some data here. So you can do a visual inspection of your results, and you can check it, and you can say, do I want to autofill that? Do I want the software to interpolate that? Well, probably not actually, because I want my contact points to be spot on. So I can then go back in and rescan that area and stitch in the rescan. And I think that is a really useful process. So when you're trying the software out, it's not only how ergonomic and easy the hardware is to use, but it's also some of the workflows within the software that are important and really useful to get to the bottom of when you're making a decision. The second issue that we see a lot of is artifact caused by saliva or soft tissue. You know, we saw it on those videos there. It's almost impossible not to catch some soft tissue, cheek, and so on and so forth. And how do you mitigate that? Also, obviously, saliva can cause multiple path propagation of the light, which can cause measurement errors, as can reflection from the surface of the crown, or from a filling that might be reflecting the light. So there are various mitigation, and they're mostly physical. You can use saliva pads, obviously. You can use Optigate, which a lot of people do. It makes it a lot easier. Obviously, use aspiration. And a lot of the software now has automatic data cleansing, and that is very powerful. It'll do it in real time as you're scanning around. And for areas where that might not be spot on, then you obviously can do manual data cleansing as well, lassoing areas and removing them. Or as we can see bottom right here, where we've got a double scan and it's not stitched the image together, probably because of a reflection of a filling there. You know, you can get software to wind back a couple of steps, almost like replaying a video, and then roll forward again with the scan, another way to remove it. But having the control and power over that, I think, is really useful in terms of getting a good final result. And you can see some of the soft tissue areas here that have been caught, the cheek that's been caught in that, and basically that can be automatically lassoed and removed. The third scanning issue that we've got is misalignment in the bite scan, and this is really quite common. That is due to basically as we said, the buccal bite scan not aligning exactly with the individual model scans. And the more data you can provide here, capture sufficient data, and that'll give more information. You don't want to capture too much data on the individual arch scans, because redundant data, too much data, can cause stitching issues and meshing issues. But certainly when you do the buccal bite scan, take your time. The more software points you give, the more data you give, the better it's going to line, and the better the occlusion is going to be of your final restoration. So the fourth issue that we've come on to talk about already is subgingival preps. And the mitigation here is to use retraction cord, aspiration, Optrogate, and near infrared scanning also helps. And we can see some challenges here that also are helped by the move from monochrome STL non-texture scanning to PLY scanning, because the color and texture information that you're getting from the recording gives you extra pointers to where the margin might lie. It's easier to see in color and in change in texture the difference between tooth and soft tissue than it is in monochrome. And you can see how that might happen here if you look at these scans, in that because the gingiva isn't fully retracted, the software is basically interpolating the data and filling in, which makes a measurement inaccuracy in the margin position. So certainly color information and texture information is really important in alleviating some of those issues. So there we are. We're just within the hour and a half, as I promised. I think we've got 5 or 10 minutes for questions. I thank you ever so much for listening today. It's been an absolute pleasure to talk to you, and thank you to all the team at Tipton and Paul for inviting me along to do that. This is the second in a 3-series lecture. So the third one is on, I think, the 22nd of June, and that's on 3D printing technologies. MyNewI.io is a new website that we've got up, and this is a kind of comparison site of all the different intraoral scanning technologies. So take a look at that. It'll be up live shortly, and you'll be able to get a new look and comparison of all the sorts of different technologies, which hopefully you'll find useful. But thank you ever so much for listening today. I really appreciate it. I'm going to ask Louise to come back in now and to moderate.
Yeah, I think you've got a few questions in the Q&A box at the bottom, if you can see that.
Yeah. So the first one is, can you export STL directly without going through a line to clean up? Yes, you can. So a line have just announced, actually, they used to cleanse the data manually offline in the cloud. So often people would scan the data and it would not appear, as far as the client was concerned, the scan had been uploaded and done, but actually as a lab we wouldn't get that data for some time afterwards because it was being manually cleansed. They've changed the workflow and process now, and we can get the data directly and we can cleanse it and work on it in the lab, or we can then elect to get them to work on it. So yes is the answer to that question. How much is the cost of an iTero 5? I'm not actually getting into pricing on this. That's something to discuss with your local rep. Can I confirm if Medit blows unfiltered air into the mouth? I'm not aware of that, to be honest with you. So that again is something to ask your rep. I think they've got a heated mirror, but I'm not aware that the Medit scanner actually blows air onto the prep. I may be wrong. Can you address the focal depth of scanners? Yes. So obviously laser scanners they have an infinite focal depth. Structured light scanners, typically the focal depth is about 10 mil. So depending on how the scanner is designed, you'll either rest the wand or the tip of the wand on the teeth, as we saw in the video from Align, or you'll use a kind of pen hold with your sort of second finger just resting on the patient's chin or intraorally on the teeth, just to guide the wand around and get a fixed distance. But the software is pretty good, and it will compensate for variations in the distance. One thing that's not ideal is having a jittery hand and moving around, because you're going to, the software will probably compensate for it, but obviously you're having to capture a lot more data to eliminate that jitter, and that creates large data sets. And where you create large data sets, you can get stitching issues firstly, and secondly, they're large data sets to work on, so they take longer to process in the CPU, in the graphics engine, and longer to transmit. How important is the sensor size and bit depth for accuracy? So the bit depth, by which I presume you mean the number of megapixels within the CCD camera, is extremely important. So the more megapixels you've got in the camera, the better it's going to be. But that is kind of balanced with the algorithms that use to stitch the data. So it's a kind of trade-off between the measurement, physical measurement uncertainty of the scanner introduced by things like optics and the cameras themselves, and the software interpolation. So I would say actually, it's probably as important, the software algorithms are as important as the physical hardware scanning in that process. Which scanner would I choose myself if I need to buy one? Well, as I say, all of the hardware is really good now, and you know, I wouldn't necessarily I would suggest that you look at the application and then work backwards from that, and that's what my new .io is all about. It's about creating a simple path for you to get through this selection process. I wouldn't necessarily recommend one scanner over another. I would first of all look at what your particular indications are and what you want to use it for, and then work back from that point. So I'm sorry to duck that question in a politic way, but it's very difficult to say one scanner is the scanner and just go and buy that scanner, because I think different indications, different applications. And prime scan over 20 millimeters. I didn't know that actually, but that's very good. I would have thought that 20 mil different, 20 mil is a lot, actually more than is probably needed, but that's good to know. Thank you ever so much. If there aren't any other questions, I just again thank Paul and all the team at Tipton for inviting me to speak today, and hopefully we'll catch some of you on the 22nd for 3D printing.